So, so tonight we're talking about digestion, and sort of over the dinner hour here. So maybe you're digesting your food or while we're talking. But I look forward to having a dialogue with you about it. So as we're going to move through, we'll talk a bit about reflux. We'll talk about small intestinal bacterial overgrowth. We'll talk about gas and constipation and diarrhea, and a few other sort of topics. If we don't cover a topic that you're interested in hearing about, let me know and we can cover it on the backside. I'm going to try and leave some time so we can have some other conversations that might be more relevant for you. So I look forward to that. And it's nice to have you all here. I appreciate your support of what we're doing here. And we do this once a month. Often I'm providing the presentation, but I'm trying to get other people to come in, other experts to get their point of view too. And that way we can all learn from folks other than myself. For those that haven't been here before, welcome. I'm a physician, Brad Jacobson. We run a practice called Blue Wave Medicine. And we have a range of about 18 different healthcare practitioners that are part of our ecosystem that work with us. And they range from chiropractors to nutritionists to personal trainers to physical therapists to chefs to meditation teachers, chiropractors, body workers, myself, nurse practitioner Julia, that some of you both know us. So we try and really work as a collaborative, as a collective, and we do this once a month to provide some additional help as a community service and to really keep everyone educated as best we can. So welcome. So I'll share some slides and then we can take it from there. Let's see, hopefully you'll be able to see the slides. So give me a moment here and I will pop those up. Okay, and let me try and do this in a manner that, see if that works. So if you can let me know, are you seeing that in presentation mode or you just see the one screen? Rather than a split screen there, I'm hoping you can just see that as one screen. So maybe if you guys can let me know. So, so this is entitled Digestive Health, Laying a Foundation for Optimal Health. And really the gut really, not in presentation view. Okay, let me just stop sharing and try one more time. All right, hopefully that one works. So great, so is that better? Linda, you told me it wasn't not in presentation view. So hopefully Linda, yeah, great, thank you. So so the doorway, as many of you may know, that the gut's really the doorway into our being. And there's many doorways into our being, right? But if you think about breath as we breathe, it's an entry point into our lungs, into our body, as we unfortunately all know through COVID. And same with the gut, that portal way really through the gut, starting from the mouth and out through the anus, is another portal way into the body. And if you think about the gut, it's important to think about it sort of like the outside of our skin, right? So our skin itself is an exterior barrier. The lung lining inside is a barrier, and the gut lining is a barrier, but it's also a portal of entry. And so if you think about that, these are ways that we get nutrients and at the same time excrete, right? So if you look at the skin, we're excreting toxins out through sweat. At the same time, we absorb things through the skin as well. And if you think about our breath, the same thing, right? We bring in nutrients like oxygen and we expel carbon dioxide through our breath. And for the gut, we bring in nutrients when we think about our digestive health, everything from carbohydrates, and we break down that into glucose, from proteins that break down to amino acids and fats into triglycerides and all their different components of triglycerides and free fatty acids, and then all the vitamins and minerals right through the gut. At the same time, stuff can get through the gut into our body that doesn't belong. Take it, for example, you eat some bad food and then you get diarrhea, right? So some bacteria crosses over into the bloodstream at times and can then cause problems. So we're going to explore some of that as we walk through some of this. And the intention is to recognize the importance of digestion really for our being, not just at the gut level, but really through the body. So we'll walk through some of that, what we mean by that. So let me, so just, to give you an overview of the bit of the anatomy, which many of you know, but just sort of a bit of a refreshing, is to really think about, okay, so what happens? You have your mouth, then you have the esophagus, which is the pipe, that orange pipe that we're showing there, that comes down, that connects the mouth to the stomach. Then your food drops into that stomach. From the stomach, we then go into our small intestines. From the small intestines, we move to our large intestines, which is green in this picture. And you have different parts of these of the large intestine, or the colon, which is you can see here, the cecum is sort of that pivotal point. And then you go to the ascending colon, the transverse colon going across the body, the descending colon, which is dropping down the left side of your body from the spleen down into the left corner of your body, left bottom near the pelvis. And then it comes around the corner through the rectum and out through the anus. And then you have these other organs that help you digest food. So the pancreas being one of them, and the biliary tree, or the gallbladder and the common bile duct, and then you have the liver. So that's really what we're talking about. All these different organs need to work in conjunction in relation to one another to have proper digestion. So if you now think about how do you create an optimal healing environment for all this to have the maximal nutrient absorption and proper digestive function. So on the left-hand side of the slide is when things are in balance. And on the right-hand side of the slide, the negative balance is where things are out of whack. And so I invite you sort of just to scan this, to really look through, okay, what does that mean? And it starts with the mind. So the more stressed we are, we get more sympathetic overdrive. Now, we always have parasympathetic and sympathetic sort of tone happening, drive, but there's often going to be an imbalance. We have more sympathetic drive, and that's the part of the brain that's experiencing fear, stress, anxiety, right? So heart rate goes up, sweating may happen, dry mouth, difficulty sleeping, agitation, right? That's sort of all those pieces. That tells you when that's happening, what happens? You get more acid production in the gut. You get decreased peristalsis, which means decreased movement of the general natural movement through the gut, through the small intestines, the large intestine, and even the esophagus. So things can get out of whack just from the mind alone, right? Now, parasympathetic tone is more the calming part. And it's sort of like braking gas, and you want that parasympathetic tone to engage. So what can we do to encourage that? So a bit of it is really around self-care and self-regulation, coming back to the self. Being in the Bay Area, we can talk about this, and thankfully it's become more and more normalized through the nation and through the world for that matter. And a lot of it comes originally from India, from Asia, and from traditional cultures, even Native Americans here and Indians throughout Latin America, which is really about general practices that sort of bring that sort of regulation, whether it's through yoga practices or Tai Chi practice or meditation or walking in nature, etc. So I'm spending a fair amount of time talking about that because given the root cause of much of our dis-ease relates to stress, either as a primary factor or as a contributing additive factor. It's important to sort of find some place in your life for that on a daily basis, even if it's 5 minutes a day, which is often what I tell people, and many of you that know me I speak to this, really trying to emphasize this, twice a day, 5 minutes is magnificent for you. And that it creates a controlled environment where you do a bit of something, whether it's play guitar, walk in nature, do a bit of a meditation or yoga, whatever it might be, 5 minutes even. It's a controlled environment where you can learn to cultivate that sort of patterning. And then you can move into your life, the uncontrolled environment. So you have your controlled laboratory. And if you go to a yoga class, It's like a controlled environment where things are nice and serene and things are set up nicely for you. And then you walk out into the world and it's chaos, right? But that in that controlled environment, it allows you to cultivate these practices and create these patterns and these neural patterns in your own brain. So that you create these neural loops in your brain that then you can access as you walk through the chaos of your day. And so the hope is that you could not go from like out of the laboratory controlled environment to chaos and you need to go back to the laboratory, yoga again. But the hope is over time, you can bring some of that practice, whatever it is that you're doing, into your daily life and start to weave it in and start to be like, oh, let me slow this down and redirect so I can actually come back to that calm state. So that's the mind, which we could spend hours on. And then if you go through the rest of the body, you can see there acidity, pH on the stomach, affecting also the mucus layer that's nice and protective in the stomach. Moving down to the small intestine where you're talking about bacteria. Do we have the right bacteria in that small intestine? Do we have the proper lining, the permeability in that small intestine so that we have an intact gut immune barrier with the right bacteria in there and the low bacterial growth, particularly of the wrong bacteria? And then in the large intestine, the same sort of thing. Do we have the right bacterial balance in that large intestine? And then how frequently are we able to move stool through us and out so that we have regular evacuation rather than constipation where things get stuck. And during that time, things can ferment and things can actually become carcinogens and lead to cancer and other problems. So that regular sort of bowel movement. So that's sort of an overlay. And then if you think about that now, I mentioned this already, but just think about digestion. What are we digesting? And we think about our food, it's in three big categories, right? We have carbs, carbohydrates, and those are broken down to sugars. And it starts in the mouth, actually, by the saliva. And then pancreatic enzymes, amylase, and liver enzymes will break things down in the small intestine, one component of it called the duodenum or duodenum, which is just after the stomach. And then you have proteins, and those break down from proteins into amino acids in their smallest component. And that happens thanks to stomach acid. If you're taking proton pump inhibitors like omeprazole, Nexium, things like that, then that's a bit of a problem. We'll talk about that later because you don't have the stomach acid to really break it down all the way to amino acids. And Pepsin also is in the stomach that does this work. And then the pancreas releases something called trypsin. And again, that's in the duodenum. Then fats are broken down into smaller components called micelles and fatty acids. And that happens thanks to the pancreas. It releases something called lipase, which breaks down lipids, which are fats. And then you have the biliary salts in bile, which then is released in the duodenum also to help break down these fats. So those are sort of things to think about. That's why I showed you the map earlier. Oh, that's how the liver and the pancreas contribute to breaking down foods, right? And the saliva in the mouth, which is why we want to slow down when we eat and allow things to chew things well so that it gets nice and broken down, makes it easier on the stomach and the rest of the gut. It also, just by stimulating stuff in the mouth, actually triggers the pancreas to start working even before the food's actually dropped into the stomach or the duodenum. The pancreas starts kicking in as soon as food's in the mouth and you're chewing and you release the saliva into the mouth. That triggers, there's a reflex that triggers actually the pancreas and other parts of the body to start working already. So eating foods nice and slowly and mindfully is important. So then you've got the large intestine, and that part of the gut is what absorbs most of the water. So when you're having diarrhea, like watery diarrhea, if you ate something bad or you're traveling or what have you, that's often coming from the large intestine. It stops absorbing stuff because it knows there's a toxin. And so it shuts down. And then all that water that's left that normally gets reabsorbed in the large intestine, it's shut down, it doesn't bring the water in. And so out it goes, right, into the toilet. So you get some minerals as absorbed, electrolytes, some of the fibers that are digested by bacteria, and others that are non-absorbable. That all happens in the large intestine. And then the motility happens from these segmental movements, and this what we call them before, this peristalsis as well in the large intestine. And so you want this plentiful bacteria there where they actually, it helps digest some of the remaining carbohydrates. Actually, that's where gas production occurs a lot from certain bacteria in the large intestine. And that's where you can manufacture certain vitamins as well, like vitamin B and vitamin K. So if you think about nutrient absorption, most of it happens in the small intestine. And it really is important that you have a good barrier, a good lining there to allow that to happen. And it requires energy. So what we call adenosine triphosphate, which is ATP, requires energy to use these pumps that bring the nutrients across into the bloodstream, from the gut into the bloodstream. So some causes of problems in the intestine relate to permeability issues, which I talked about earlier, this leaky gut syndrome, intestinal permeability issues, the SIBO or SIBO, which is small intestine bacterial overgrowth. And that's when there's large intestine bacteria ends up in the small intestine. And that can happen sometimes actually with probiotics. There's been some studies looking at that, which has changed my recommendation around probiotics to say probiotics can be helpful, but it's important to play with it a little bit. When you take your probiotic, do your bowels change for the better? And if so, great. Sometimes people start having, we'll talk about it later, gas and other bloating issues that could be SIBO. And if they're on probiotics, I say, you know what, why don't you stop for a month and see how that changes your gut? And then still things are problematic, actually it might be worth doing a test, which we'll talk about later. And then also bacteria, microflora. What's going on in all the microorganisms in the gut lining? Or is there Candida in there? Are there other sort of non-bacterial things in there that are yeast producing? Are there unhealthy bacteria in the gut, and where? And then problems can happen with the different organs that go into the gut. So pancreas, the gallbladder, and biliary tree, where they're not releasing stuff properly, and you need some enzyme support to get those things properly digested. And then, of course, intestinal infections can affect absorption as well. So that's a bit of an overview. If you think about vitamins, electrolytes, and water, the vitamins that are fat soluble are A, D, E, and K. And then you have these water soluble ones, which are B and C. So you don't want to take too much supplements of vitamin A, D, E, and K because they're fat soluble. Whereas the B and C, for example, you'll just pee it right out, right? And so, if you take a multivitamin, often your pee turns bright colors, and often that's from these water soluble vitamins. For B12, some people are low in vitamin B12, and there's various reasons for that. But in part, it can be related to the fact that if your methyl tetrahydrate reductase factor, you have a mutation, that genetic mutation, the MTHFR mutation there, that will require that you have more methylated compounds around the vitamin B12, for example, to allow for better absorption. Another one is that there may be problems with your ability for the intrinsic factor to bind to B12 and then get absorbed, because in order to absorb B12, when you're ingesting it orally through a supplement or through food, is it has to bind with intrinsic factor and then get absorbed up. And sometimes they have problems with that binding. And so that can lead to other problems. And then you have the electrolyte. So, and think about calcium, for example, and to realize the relationship between vitamin D, which helps calcium absorption. And then we talked about water and how that can be absorbed. So let's move to sort of a conversation around health issues. So a lot of us talk about food allergies and food intolerances. So allergies, when I think of allergies, I think of, a peanut allergy, right? Where people have a big anaphylactic or large reaction to certain foods, which people can have. Gluten, people can have a gluten allergy where they truly have celiac disease, where they have an immune response to this food group, that they're high, shellfish, for example, right? Those are really serious allergies. And then you have things that are more like intolerances. And those are the stuff we talk about. I can't gluten, I get an upset stomach, or I get a headache, or I get a rash, or my psoriasis gets worse. Dairy, corn, soy, there's a range of things that people react to. And those are more of an intolerance. They'll have potentially an antibody response to it. But again, it's not something that leads to anaphylaxis, right? Where people can have difficulty breathing, swollen lips, and things like that. So if you think about that for a bit more, it's very underrated, right? So it's more and more actually of the public. Many of you know about this than doctors admit to this. But But we all know it's true, right? We used to say, oh, it's such a rare condition, celiac. And then they realized, oh, actually, it's not as rare as we thought. And then, oh, there's a whole nother layer of people that just don't tolerate gluten well. But it's taken decades for doctors to admit that as being a reality. But many of us have figured that out on our own, through our own trial and error, or through working with naturopaths or more holistic oriented, particularly non-MD providers. And so there's ways to check for that. We can do testing, or you can just do, and the testing will be through the low-tech method of, I'm going to cut out a certain food group, call it dairy, for a month and see if I feel different. See if my rashes get better, see if my headache improves, see if my gut bloating changes, whatever it might be. See if my joint swellings or my pain in my joints get better. And then there's more high-tech approaches that aren't necessarily better, but often are more motivating for people. So we'll do a blood draw and we'll see if they have an antibody response to dairy or other things. And often people say, oh, well, if you show me the data and it shows an abnormality, then I'm more willing to cut this food out because I love the food and I don't want to have to cut it out. I'm in favor of doing sort of both. What I tell, in the testing isn't 100% sensitive or specific, meaning there's a lot of false negatives and there's a lot of false positives. So sometimes it won't show dairy, antibodies to dairy, yet they cut it out and they feel better. Sometimes it shows that they have antibodies to dairy, yet they cut it out and they don't feel any different. So I sort of am in favor of the low-tech method frequently, but a lot of people are motivated by the information through a test. So we'll do both often. All right, so let's talk a bit about constipation. A lot of people have it. So, and a lot of people don't like to talk about it. So I'm open about talking about our bowels and constipation. So here we are talking about it. Many of you probably know this, but I'll just share it with you anyway to be really emphasize certain points, which is we as a country don't eat enough fiber, you know? And there used to be a lot more fiber in fruits and vegetables, as well as in the grains that we eat as carbohydrate. And that's all changed, right? So there's a light, you know, we eat white rice and we eat wonderful enriched white flour-based pastas that are delicious, right? And those have a paucity of fiber in it. And even our fruits and vegetables tend to have less fiber than they used to historically. And we eat ones that are sweeter and have less fiber in them because we've hybridized towards that. If you take corn as an example, you know, the sweet yellow or white corn now is nothing like what Native American Indian corn used to be, right? Which is way more nutrient dense, way more fiber, and a lot less tasty, you know? So getting enough fiber is really important. And we know that's associated with reduced risk of colon cancer. We know it improves cholesterol metabolism, reabsorption, basically. So you have lower cholesterol levels. And we know that it helps create healthier bacteria in your gut because they use it and digest it, and which allows those bacteria to even multiply more, the healthy fiber, the healthy bacteria in our gut. So lots of goodness around it. 35 grams is a fair amount. You've got to be focused on that to get that much. And a lot of times I tell people you can supplement with psyllium and, you know, other ways to get to that level. You have to make sure you're drinking enough fluids though, because if you don't, it becomes a cork, right? So this fiber becomes doesn't have enough moisture in it, and so it starts to become literally a cork in our gut. So you want to have a lot of fluids to help make that full, and then the stools become bulkier and fuller, and they pass much easier through the bowels. And then part vegetables as well. So the more vegetables, the better. We've talked about this in other conversations, other workshops, where every serving of vegetable that you move up the chain on from, even if you don't like vegetables, you're doing 1 a day to moving to 2 a day or 3 servings of vegetables a day, which is roughly a fist size full, typically it's a serving, really results in a reduction in death and morbidity by 6 to 8% with every serving, up to 42% reduction. If you compare people that don't eat any vegetables to those that eat 7 servings a day, they have a 42% reduction in cancers and heart disease, autoimmune conditions. It's across the board. There's a great British Medical Journal article, meta-analysis looking at all this. And 42%, there's no pill, there's no surgical intervention that shows a 42% reduction, let alone across multiple endpoints other than eating your vegetables. So people always want the silver bullet, and the truth is it's the multi-rainbow vegetable is your silver bullet. And then fluid exercise is important. Short-term use of laxatives can be problematic. I mean, if it's long-term, but in short-term, they can be helpful. And peristalsis, which can be increases problems with age. And then some of the consequences of chronic constipation can be that you get these outpouchings, known as diverticuli. You can cause hemorrhage. And hemorrhage are basically like a varicose vein. You know, if you think about your veins and they start to dilate in your lower legs, the same thing happens around the anus because of the pressure, prolonged sitting on the toilet, prolonged pushing. You end up with their veins basically that get dilated. And that's what a hemorrhoid is, which can be very painful if they're external hemorrhoids, less painful, or you don't really feel them if they're internal because there's no nerves there, but can lead to bleeding and other problems. Colon cancer we talked about already, and then all the just uncomfortable feelings of gas and bloating and lethargy. And then the opposite is diarrhea, right? So people can have both, by the way, but if people are sometimes prone to one or the other, and there's different types of diarrhea. So there's a whole range of them based on what the cause may be. So IBS, or irritable bowel syndrome, is something that's common for many people, and that can be pure diarrhea. Pure constipation is typically a predominant of one over the other, where I'll have predominant diarrhea, the IBS, or predominant constipation IBS. And a lot of that's affected by stress, the mind-body stress connection. And it's been shown to be that there's cognitive behavioral therapy, CBT, hypnosis, mindfulness-based stress reduction, or meditation. Again, that mindfulness piece affects that sympathetic, parasympathetic system. Hypnosis can get into the subconscious or unconscious aspects and access some of those components that are creating these different habits, these different neural loops in our brain. And same with cognitive behavioral therapy. Then there's something that combines cognitive behavioral therapy and mindfulness called mindfulness-based cognitive therapy. There's something else called ACT. So there's a range of different therapeutic options that help really address that mind-body relationship, which affects our physiology and ultimately can affect folks with IBS in a positive way. And then the stuff, if you think about fiber, hydration, exercise, in mind body. So those sort of four that we have there in hydration, so points number on this list here would be points number 4, starting with fiber, mind body, exercise, hydration. Those 4 points there are really sort of a core. And then you can, as we talked about earlier, this elimination diet is, okay, I'm going to eliminate one food item for a month and see how I feel. Or sometimes you do a full elimination diet, which is a full list of different categories of foods that people are either frequently or infrequently intolerant of, to see if it makes a difference at all. So the nice thing about that approach is doing it all at once is in a month, you sort of said, all right, I'm cutting out everything that possibly could cause the problem for a month. And then if nothing changes, I know it's not my diet. It must be something else. Versus I'm going to do 2-3 weeks at a time, one food group, and then move on to the next food group. And that often can take months because there's 8-10 different food groups to try and explore. The bowel microbiome, we already talked about how that could be affecting your symptoms. And then there's some great treatments, right? So peppermint oil is wonderful, and there's different products out there that have peppermint oil in it. There's this combination herbal formula called Iberogast, which typically you can only really get online and made out of Eastern Europe. It comes out of Eastern Europe. And then you have cromolyn, acupuncture, and then this one piece of note, if a diarrhea predominant IBS, it's worth also looking at bile acid malabsorption as well. And to think about some treatments for that. So there's just to show that, thinking about probiotics, if you think about the first bullet line there, the bowel microbiome, that, thinking about, okay, let's put in some bacteria that might be healthier to change that microbiome, that environment, the microorganism environment in your biome, in your gut. This is a randomized controlled clinical trial looking at 122 patients where they received Bifidobacterium bifidum a specific substrain called, MIMBB75 versus a placebo pill. And they showed really, clinically and statistically significant changes, where 47% versus 11% in the placebo group reported adequate relief. It's a fair amount. And they looked at response rates, 60% almost versus 20% had responded well to it. And they had improvements in pain, bloating, urgency, and this global symptom score that they came up with. So, in thinking about side effects, they really didn't see anything. There's no difference between the folks that got the probiotic and those that got placebo. So it was really one of the early studies to show that a large study that was well conducted showing this difference by just the use of the specific strain of bacteria, which particularly resides in the large intestine. All right, so what else could you use? Rifaximin, which we also use for small intestinal bacterial overgrowth, SIBO. And they looked at 1,200 non-constipating people with irritable bowel syndrome, and they did a randomized blinded trial where they received placebo versus this antibiotic that's non-absorbable, meaning that you take the pill, it goes into your gut, it doesn't go into the bloodstream at all, and it kills bacteria that doesn't belong there and seems to be helping. Now, the thing that I don't understand is maybe, and they haven't looked at this, is it might be that these people that responded, you see their 40% versus 30% symptom improvement, which isn't quite as good as this one, where you have 57 versus 21%, right? Or 47 versus 11%. That's a big difference. You have like 4 times more people responding to the adequate relief rating scale, and the responder scale, 2.5 to almost 3 times more people responding. Whereas this one, you've got an additional, a third of the people are responding more. So it's a big difference in response rate. But this group might be, a lot of them might have SIBO that was undiagnosed, small intestinal bacterial overgrowth. So you'll see this later when we talk about this as a treatment. Big study, and they showed benefit, 10 weeks of this treatment, which is longer than you normally treat for SIBO, by the way. It's normally just 10 days. So what about reflux, heartburn? A lot of times it can be affected of when you eat, how much you're eating, what you're eating. That can really affect your heartburn experience. Most of you probably know this, but I'll just say that you want to be not eating within 2-3 hours before going to bed, right? Because you're lying flat, and that food if it's still in your stomach, particularly as we get older and it doesn't digest as quickly, it's still sitting in the stomach, will come up into the food pipe called the esophagus, and you'll feel this burning sensation or some other sensation. And then the quantity, which relates to the same principle of you eat too much food and it's not able to get out of the stomach in time, so it starts overflowing and comes back up, even if you're not going to bed quickly. So, and then certain foods may be slower for you to digest, or maybe your body doesn't like the food very much, so it just sits in the stomach, and that can be causing problems. So I've had people, they cut out gluten, they're doing much better, or they cut out dairy or other types of food groups, and they realize, oh my God, that's what's causing the problem. And then sleep hygiene, and that sort of relates to timing of when you go to sleep, as well as if you're having reflux, you'd want to lift the bed up so that the head of the bed is higher than the foot of the bed. Some people prop themselves up with like big, thick pillows, but the problem with that is you're bending at the waist typically. And that bending at the waist, typically people have a little bit of a gut. And so that gut is pushing against the pelvis, and so then that pushes back up. So now you get pressure pushed against the stomach from your belly, from your sort of gut, that's pushing, which causes more reflux. So you want to stay flat on the bed and just lift the head of the bed by putting bricks or books or something. So you're lifting at 6 to 12 inches, the head of the bed is being lifted up. And that angle change can help folks. Stress increases heartburn. We talked about that in the very beginning. And then what are some of the things you can use? I'm a fan of diglyceride licorice, DGL, can be quite helpful. There's other sorts of herbals as well that are coating, like plantain, like marshmallow. They're coating. They put a nice coat on the stomach. That can be helpful. D-limonene, which is made from orange peel often, is given every other day for typically 20 days, 10 doses. Sometimes you have to repeat that, so it's more like 40 days. So you do 20 doses every other day. And that can often help folks with reflux. It's worth thinking about H. pylori. A lot of times it's not so much coordinated with it, but if people have dyspepsia, which is really the stomach discomfort, which can be bloating or pain in the stomach itself, it's important to think about Helicobacter pylori, H. pylori. And you can test for that with a stool antigen test or antibody test. And then you can treat for that if you're positive. When it comes to reflux, again, it can be a hiatal hernia people can have, that can increase the chances. It can be the problems with the peristalsis we talked about, and all the other things I mentioned earlier. So there's also herbal formulas that are traditional Chinese medicine-based, TCM-based, that can be used as well. Interestingly enough, melatonin, which people use for sleep, it turns out that can change the sphincter tone of this area between the esophagus and the stomach, called the GE junction, or gastroesophageal junction, has a sphincter there that opens and closes, and that can get relaxed. And so melatonin will actually help keep some better tone on that. And so people can use that before bed, and that can be helpful for reflux as well. Things that affect also that tone is tobacco, alcohol, caffeine, chocolate, tomatoes can all affect that sphincter tone as well. So medications that can be problematic and helpful at the same time. So proton pump inhibitors, H2 blockers, and TUMS can really help symptoms. They can also mask symptoms as well. So what happens with these proton pump inhibitors and H2 blockers, it'll reduce the acid production so that you may be getting reflux, but you don't have the burning experience because it's not a low pH. The pH typically of 2, 2.3, or up to 3, a highly acidic environment, because it's so acidic, it helps both to break down food, but also protect against bacteria that come in. It will kill the bacteria because it's such a high acidic environment with a low pH. You get rid of that with a PPI, which reduces the pump, which is the hydrogen pump. It reduces that. Hydrogen creates hydrochloric acid, which is acidic. And so it reduces that pump. And therefore you get a less acidic environment, but you may still be having the reflux, right? So that's been prone to, we'll talk about more of this down actually in the next slides, but those are other treatments, but we sort of ideally want to use them in short term if we can. So thinking about H2 blockers and PPIs, like omeprazole, Nexium, things like that, proton pump inhibitors, there's a large study, almost 750,000 people in Sweden, and they found that this acid suppression was associated with a 50% increased risk of asthma. And the thought behind that is that you're getting this reflux, you don't really feel it. It's a little bit unclear exactly what's happening, why this is occurring. Like, okay, so it's less acidic environment, you're getting the reflux, and we think that there might be some silent aspiration of that reflux into the windpipe and through the respiratory tree, which then irritates the respiratory tree, and that could cause it. Or it's possible that leads to bowel integrity issues, which we'll talk about in a moment, leading to meaning that you're having leaky gut that can lead to a hyperimmune response that can lead to this autoimmune respiratory condition we call asthma. But what we do know is there's this increased association. So what I mean by this acid breakdown thing we talked about earlier in the very beginning is what happens is you have acid in your gut, typically with a pH that's quite low. And then that acidic environment activates pepsin, which helps digest the protein. So you have protein that becomes pepsinogen, which then breaks down to amino acids. But if it's not highly acidic, you can see that the pH is 1.8 to 3.2, which just means it's a very acidic environment. Then, a pH of 7 is sort of that neutral zone, and above pH is considered the basic environment. So as you move the pH upward, being on a PPI, for example, then it doesn't do as good of a job breaking down. The pepsin can't really do as good of a job breaking down into amino acids. And you're left with these intact proteins, partially digested proteins. And that can activate an immune response. And we found that after 5 days of a proton pump inhibitor, it increases the pH to greater than 4. So while people feel better because they don't feel the acid, there is some potential downsides around this breaking down of your protein all the way down to what it's supposed to be, which can lead to permeability and leaky gut issues. And what we also know is that you come off the medicine, people get more reflux. So it's real important to, I'll show you the next slide, come up with a protocol like, okay, I'm doing this for a short period of time to get myself relief, typically a month, and then I'm going to slowly taper off it, because I'm hoping that by the acid reduction, that any ulcers that I've developed or any irritation that I have is reduced because we sort of reduced the acid environment. I've stopped drinking my alcohol. I don't take my NSAIDs anymore for Motrin or whatever, the antibiotics I'm off of. And so now I'm going to try and heal the gut. There's a whole protocol for that. And then I'm going to slowly come off this treatment. And so that would include, you could see this slide is basically showing you start therapy, they stop therapy on week 5 or 6, and you could see that bump up, the blue dotted line is the symptoms getting worse at week 7, then slowly getting better over the next few weeks. So what you can do is do a slower taper when you're coming off the proton pump inhibitor. Avoid foods that are triggering that we've already talked about. Use these things I was telling you about earlier, like DGL, slippery elm, marshmallow extract, aloe vera also is really great for coating. There's something called sucralfate, which is a medication, which actually also does a great job of coating. It's like a white pasty coat. And then melatonin we talked about for that sphincter tone, Aberogast or peppermint oil we talked about earlier can be helpful as well, and acupuncture. So this is sort of what I recommend people do as a protocol to come off that medicine and see if they can do that. All right, so this leaky gut idea, this intestinal permeability. So let's talk about that for a moment. There's these things called tight junctions that sort of are like, imagine like, guys at the front of a bar or a club, that are sort of the guards letting people in, who's allowed in, who's not. And that tight junction membrane there, you want really tight so that things don't get across into the bloodstream that don't belong. And there's 3 modes of defense. You have the a mucus barrier, you have the bacteria, and then you have this local immune system, the gastro-associated lymphoid tissue, GALT. And so then what about testing? Well, there's different ways to test for it. Primarily, you can do antibody testing. You can also do this testing, which is sort of more of a functional test, which basically says you drink the stuff and then you go pee. And then we send that to the lab. And they look in the urine to see what showed up in the urine. There's lactulose, which is not supposed to show up in the urine because it's not supposed to cross the barrier into the bloodstream and end up in your urine because it's a large sugar. And then there's mannitol. And mannitol is a small sugar, and that's supposed to all cross over into the gut and not be in the stool. It's supposed to go into the gut and then cross over into the bloodstream from the gut, and then ends up in your kidney and you pee it all out. So what you tend to do then is you send the test in and it should have a high amount of mannitol and no lactulose. And that's a good functioning gut, meaning that there's no leakiness happening. And if you don't have that, then you've got problems. So you've got malabsorption can happen if you're not getting all that mannitol across because it's not getting across like it should, and you're getting some lactulose across, which doesn't belong there. So you're getting malabsorption. Or you have permeability issues where you end up with the stuff that's not supposed to leave the gut, the lactulose, coming across when it doesn't belong across, right? So, so that's how you do the testing of a functional test. Some of the causes of this leaky gut issue can be acute or chronic infections. It can be the small intestinal bacterial overgrowth issue we talked about earlier, which we'll talk about more in a moment. Medications can cause problems in the gut, in the stomach, like ulcerations and gastritis and things like that, and can also lead to intestinal permeability issues further down in the small intestine. Alcohol and other toxins as well. And then you have sort of the physiology, which we talked about already, which is the mucus barrier. You can talk about medications that can disrupt that mucus barrier, like Motrin, Aleve, Advil, these non-steroidal anti-inflammatory drugs, chemotherapy, stress we talked about already, infections, not having enough fiber. Then you've got the immune system itself, which can be affected by infections, stress, and then food that your body doesn't react well to. And then finally, the microbiome itself. So using antibiotics can disrupt your microbiome. Not to say that you don't use antibiotics when needed. You should use them when truly indicated. But then you need to sort of have a gut rebuilding program to sort of bring you back, nutritional issues and infection and stress. You can see infection and stress is really across all of this. Okay, so if you're looking at the gut itself and you're trying to think about the intestinal health, this is sort of just a picture to help you sort of process that a little bit. Up above is a healthy gut, or the tight junction there that everyone's next to each other side by side and you can't get through, and they let you through if you belong through, but otherwise they don't. And then down below is just some disruption where things are getting through that don't belong, right? And these things that are getting through, like that sort of star-shaped thing that's coming across, you could see when it doesn't belong across, even if it's a partially digested protein that's not down into amino acid components, it's partially digested, right? We talked about earlier. That comes across and you get this antibody response. And so that's what we're trying to avoid, is that antibody response. And you can see there that tissue transglutaminase, IgA, immunoglobulin A, or just general AB, meaning antibodies overall, coming in and creating a systemic response that can lead to other problems in the bloodstream itself. So you can run, as I mentioned, antibody testing that looks for antibodies to these aspects of this gut lining itself. And if you have antibodies against your gut lining, that's a problem. In this case, it shows a normal result, but you can have abnormal results as well. I'm just showing you this particular person's result, which is normal. Or you can do the mannitol lactulase test I mentioned, or lactulose test that I mentioned earlier, which is more of a functional way to test it. And just so you understand, at these tight junctions, which is sort of where those red dots are here, there's a brush border. There's this thin lining that goes across as a single layer of lining of our own small intestine, our own sort of gut lining that we have, which is our brush border. That brush border is fed and nurtured by probiotics, so that are healthy bacteria, fuels and gives nutrition actually to the single line of cells that sits there regulating the border. And those bacteria are fed by what we call prebiotics, or things like inulin or oligosaccharides. So these things are then, where do we find those? Like Jerusalem artichoke and many vegetables. When you're eating those vegetables, that becomes, and fiber, that becomes fuel for the prebiotic, we call it, the fructooligosaccharides, becomes fuel for the bacteria. So now you're giving fuel to bacteria that's healthy, and so they multiply more, and now you're having more and more of these healthy bacteria in your gut, and all that healthy bacteria is giving fuel to your healthy cells. So you have this beautiful symbiotic relationship between bacteria that we want in our gut and our own gut lining itself. And that creates a healthy gut border and junction. And the amazing thing is we can regenerate these cells in 3 to 5 days. You have diarrhea, you get all this shedding, and you reboot the gut. And it's amazing in just a week. So what are some of the things you do? We call this the 4 R's. Many of you probably have heard of this, the 4 R's. And you want to remove things that are causing the problem. You want to replace things that are in need. You want to then repair that gut. And then you want to restore the microbiome. So you can see here, we don't have to go through all the details. We've talked about some of this already, but category one is remove these offending agents, right? So NSAIDs means Aleve, Advil, Motrin, right? The ibuprofen, the naproxen, things like that. We talked about food intolerances and certain antibiotics that really can disrupt the gut lining, or the milieu inside of the microbiome. And then sometimes you need to replace things. So sometimes we need betaine, can be helpful, particularly in the elderly or people who have problems with digestion. Betaine hydrochloride can help with digestion for folks that have low hydrochloride, low acid environments. As we get older, that can happen. Digestive enzymes can be really helpful as well, to help digest certain fats in particular, and proteins as well. We might want to repair the mucosa. So we could use different nutrients for that. Fiber helps with that. Zinc carnosine, which is a specific type of zinc in particular. There's all sorts of different types of zinc that we use for the common cold, like zinc glycinate, but zinc carnosine specifically for this use. N-acetylcysteine can be helpful. Glutamine, I'm very fond of, can be very helpful. Berberine can be helpful as well. So these can really help support that repair. And then re-inoculating with healthier organisms, like we talked about already. So that's sort of that protocol, the 4 R's. If you were to do antibody testing to look for sensitivity to certain foods, which we talked about already earlier, it's the low-tech method of just eliminating food groups, but you can do this other method. You can see here, so traditional conventional medicine, they just look at tissue transglutaminase antibody, which is typically just one of these 4 different ones we have here, 2, 3, and 6. Actually, this test from this company called Cyrex is even more expensive. And they also look at an endomysial antibody as well. But typically, they just do one when they run this test, and they decide whether or not you have celiac based on that one specific subtype. You can see this company does a very expanded antibody profile because there's way more things to look at sensitivity to gluten than just that one, right? So just alone here, we have IgA and IgG for 2, 3, and 6 at the bottom of the screen. And then you have gliadin transglutaminase complexes. You have gluteomorphin, which people that have antibody responses to that typically actually have a craving for gluten that's stronger than most folks do. It's interesting. And then you have all these other versions, right? Alpha and gamma gliadinins, native and deaminated gliadinins, et cetera, et cetera. So it's a much more expansive profile. And then you could run tests that are considered gluten-associated cross-reactive foods. So you may have gluten issues, and sometimes people have issues also with dairy, or they have issues with rye or barley or buckwheat, et cetera. So you could see this person has problems. I typically look at the outer range, not the borderline for folks, which is the red zone, and I give a little less credence to the yellow zone. So for someone that had this response, I would say, okay, you're having a lot of reactivity. You had a bit of reactivity here on for gluten. So let's eliminate gluten and see how you do. Sometimes I'll just eliminate gluten for a month or 2 and retest and just do gluten and see if these other antibody results for these other cross-reactive foods actually diminish, because often they will. You often don't have to eliminate all these different food groups, but often you get this cross-reactivity happening. Once you calm the system down, they no longer have the same reactivity to the other food groups. And typically gluten is the primary source. And so thinking about the microbiome overall, there's lots of different factors that affect it. And you can think about the green here, factors for symbiosis versus dysbiosis, right? Harmony versus disharmony. And some of the effects of symbiosis. So some of this is, we've talked about already, but you can see that at that sort of, for many people, breastfeeding, natural birth versus C-sections, exposure to certain microbes can be beneficial and harmful depending on how you were raised and what environment, certain favorable genetics. And then you can have other parts that relate to your immune function, these T helper cells and regulatory cells in the upper right-hand corner, neutrophil activity. And then down in the bottom, on the red sort of aspects, we talked about sort of cancer, autoimmunity, inflammation, antibiotic use, antibiotics and livestock that you're eating. Obesity can be definitely a factor related to dysbiosis, or really homogenized monoculture diet, hygiene, stress, and pathogenic bacteria. So, and thinking about probiotics, they can be beneficial in that they can actually alter bacterial adherence. So what you can see here is you have a probiotic bacteria, which is in green, a healthy bacteria. You have an unhealthy bacteria, the pathogenic one, which is in that sort of reddish rose color, spiky looking thing. And then you've got the blue triangles and the orange diamonds, or these antimicrobial peptides. And so what you can see here is this, in the schematic drawing, you can see that you have this sort of spiky things coming up against the green, and sort of there's a bit of warfare going on here, and you have this physical barrier that's protecting it, right, which is helpful from the probiotic itself. And then you have this altered epithelia, you can see here, and sometimes, and that altered epithelial surface glycosylation pattern can lead to problems. And then you can then try and get a compensatory increase in mucus production, which is sort of this wavy gold stuff here, to try and stop these guys from penetrating, right? And then you get this release of antimicrobial peptides that the body will then put into the system to try and kill these things. You could see here in it being broken apart. And there's a lot of other immune modulating aspects as well, where you have interferon, interleukins, all these different cytokines that play a role. And you could see that this happened a lot with COVID as well, where COVID would come in and there's all this activity and disruption happening by this pathogenic, in this case, virus. It wasn't a bacteria with COVID. And that's why people had a lot of gut disturbance as well. So, just to keep in mind, I talked about earlier, this symbiosis, where it's amazing, in our body, we're 90% bacteria. We're only 10% human. If you think about all the bacteria that's on our skin, that's in our lungs, that's in our respiratory tree, that's in our gut, we're mostly have foreign cells, and somehow that relationship allows us to thrive. So SIBO, we talked about a little bit already, but these are the common symptoms people can have, and a lot of the causes that you can see here. And I would add a cause for some people can be chronic probiotic use, and indirectly through antibiotic use as well. And so the treatment, the diagnosis can also frequently just do this hydrogen breath test, which basically you breathe in, breathe out, and we capture it. And if that hydrogen breath test shows the wrong bacteria, because you get this carbon dioxide and some methane and hydrogen production. So you breathe out, and colonic bacteria produce a gas. And so you get this increase in methane and carbon dioxide production. And that's a signature for the fact that you have the wrong intestine, large intestine, sitting in your small intestine. And typically there's a whole procedure they do where you fast for 12 hours and then you just fill this balloon with your breath, and then you eat a test sugar, and then you repeat that breath every 15 minutes, because that test sugar will create more, it will stimulate that bacteria to digest it, and then that creates this gas production. And then you're breathing it out every 15 minutes for 3 hours, and it's analyzing it for the hydrogen and the methane in particular. So it's normal to have the carbon dioxide, but you don't want this methane and hydrogen production being really high. So that's how they sort of diagnose it. I've diagnosed several patients with that. And then the treatment can be through antibiotics, which are non-absorbable antibiotics like Rifaximin, as well as absorbable. I typically use the Rifaximin because it's non-absorbable, as well as using probiotics, unless someone's been on probiotics and then they get the SIBO, in which case I don't reintroduce the probiotic. So gas is a lot of people experience as well. That can be from SIBO itself, I mentioned already. You can get malabsorption of sugars and carbohydrates. And so we sort of look for that as well. And, we look at basically different dietary habits and its effect on all sorts of aspects of our digestive health, right? So I really tell people, read your food labels. And if you have trouble reading them, like I do these days, just because they're hard to read and I need my glasses, which I don't often bring, I just like, if there's 5 ingredients or less on that food label, the odds are it's a healthy food. Obviously when you go to the produce aisle, there's no ingredient list. That's a healthy food because that's an apple and that's a carrot. Eat as many vegetables as you can, get enough fiber, drink enough fluids, take your probiotics. For most people can be really helpful, but not everyone needs them. Take fish oil, ideally by food that you can get through eating walnuts, flaxseed, chia seeds, or healthy fatty fish like salmon, herring, anchovy, sardines, or as a backup, as a supplement. And combine your vitamin D and calcium if you're taking Often now we reduce the amount of calcium recommendations than we used to, but it's important to get good absorption of that calcium by using vitamin D as well, and getting enough vitamin B12. So that's the tour I wanted to give today. We covered a fair amount of different subjects. I'm sure some of you may have questions. We've got, actually I've run over a little bit, but I'm happy to take a question or two if people have them. And then we can go from there. So one question people are asking here is about what's the link between the gut microbiome and insulin resistance and potential protocols to address insulin resistance. So great, thank you for that question. Yeah, so insulin resistance is a huge issue. It's frequently related to obesity, not exclusively at all, but when you have extra body fat, you store insulin in your fat. And so that results in insulin resistance. How do you figure out if you have insulin resistance? So it's easy, and you're pretty advanced if you already have diabetes, or if your hemoglobin A1C, HA1C is elevated, meaning if it's above 5.7. So 6.5 and above is diabetes, but there's this whole range, 5.7 to 6.5, which you don't have quote unquote diabetes, but the truth is it's really a spectrum. And we've unfortunately bifurcated it when we shouldn't. It's really a spectrum. And you have insulin resistance, you have impaired glucose tolerance if your hemoglobin A1C is above 5.7. With that said, people can have normal hemoglobin A1C, 5.5, but still have insulin resistance. And you know that by doing an oral glucose tolerance test, which is when you fast, you check your insulin level, which most doctors don't do, but I recommend that you do, and your glucose level fasting. Then I give you a slug of sugar, 75 grams typically. And then I repeat a test of glucose and insulin at 1 hour and again at 2 hours. And we'll see, often your glucose level may not change, but your insulin level will go up. And that predates by a decade your risk for diabetes or an increase in your hemoglobin A1C. You can look at it 10 years earlier by looking at your insulin levels. There's no reason why you shouldn't be doing that. And it's really a misfortune that we don't do that typically in clinical practice. If you have issues with your gut microbiome, again, that can cause problems in your metabolism, which we find can lead to insulin resistance, or people with insulin resistance have issues with their gut. So that it's sort of a cause and effect on both sides of that. So there's gut protocols like the 4R protocol that we just went through, and that you can read in many other formats. And I happen to have it in the anti-inflammatory cookbook that we published with Amanda Haas and myself, the anti-inflammatory cookbook that gives that what we went through today. This 4R protocol can often help heal the gut and improve its functioning, which then can be helpful down the road in how you digest foods and everything we just went through today. So I recommend that. And so, one of the repair aspects that we talked about again was glutamine, zinc carnosine, certain immunoglobulins that often come from bovine, and there's as well as some of the healing components you might want to use, and then reducing offending agents, and then that heals the gut. But a big piece relates to reducing your carbohydrate load, increasing healthy fats, and sort of allowing yourself to reduce your body fat. You can do timed eating, or what we call intermittent fasting. People do Prolon, which is a fasting mimicking diet, Prolon. There's a range of different things out there to do to try and improve your insulin resistance, so you become more insulin sensitive. So we're trying to increase our insulin sensitivity. Insulin resistance is not only correlated with diabetes, but it's correlated with lots of other health problems. So the problem is that insulin is produced by insulin growth factor. Insulin growth factor is very pro-growth oriented, hence insulin growth factor, which then is stimulated in order to create more insulin. And that can lead to increased cancer production, increased cancer risk, and increased angiogenesis, so more vascular negative vascular problems within cardiovascular risk, increased autoimmune issues. So it really is a master hormone that when overproduced causes problems. So it's not associated with memory loss and Alzheimer's. The list just goes on and on. So really what you're trying to do is increase your insulin sensitivity. I'll do one more question. I don't want to keep everyone because I realize it's 7:40. Are beans healthy? Should we take prebiotics as a supplement or find prebiotic vegetables? So beans are healthy for most people. They have a bit of carbs in them, fats and protein. So it's just realizing it is a carb, but it's mixed with a healthy carb. People worry about them because they have lectins. And for some people, they have problems with lectins. And so that's worth exploring whether you feel better without them. But in general, most people do really well. If you think about most of the planet, they take all of India and take most of Latin America. They use lots of beans, whether it's a lentil or it's a black bean or a pinto bean. Most of the planet is using them and doing just fine. So people are worried about lectins, and those are often in beans, but that's I think a small minority of people. But for some people, it is an issue. For most, it is not. Should we take prebiotics? And the answer to that is, my preference is that you increase your vegetable intake, and therefore you don't need to take prebiotic as a pill. With that said, there are probiotics that come with prebiotics, so fructooligosaccharides, and you can often get those. If you're having trouble, then you can augment with a supplement aspect to it. Some probiotics come with a prebiotic already in it, inulin-containing foods or inulin or fructooligosaccharides, FOS, in the probiotic. It can be helpful as well. Well, thanks to everyone's attention. I will post this on YouTube for others that can't make it. So if you want to forward this on to other folks, if you want to subscribe to the YouTube channel so that in case you miss future workshops, you can just subscribe to the channel. It's Dr. Brad Jacobs, Dr. Brad Jacobs. You're welcome to subscribe, and that way you can get automatically notified when we put a new video up from one of these workshops. I really appreciate that everyone showing up, and appreciate your questions. I always learn, and always gets me a little bit more focused on what's relevant for you. So I appreciate that very much. Enjoy yourself, and I wish you all well. Take good care. Bye-bye.